All right. Good morning. Sorry about that. I'm using an old laptop. Okay. So, good morning, everybody. Thank you very much for having me here today and to meet all of you. So, I'm here on behalf of the One Health team that works at the WHO. And thanks to Ludwig for explaining where the UN organisations are placed. So we might look big on the outside, but we're quite small fish in the inside. So we have the One Health country operations team. That's where I work. So it's quite a small team of 4 vets. And I'll talk about the scope and purpose of the work that we do. Just what we define One Health as, not define, but what we, how we use One Health in the work that we do, and how it relates to what we're talking about here today. Okay, so this slide is not meant to be read either, but I just wanted to show you that this is headquarters in Geneva, so you have all of these departments covering different areas of health. So then under the emergency health program, the emergencies program, One Health is way down at the bottom in one of these bottom sections. So we're actually under the health emergencies program. That's where One Health is. In terms of biodiversity, there's lots of other departments that would deal with that also, such as climate and the determinants of health, communicable diseases, they would also factor in. And sometimes we work across those departments if we need expertise in the area. So we work across, the WHO has 6 regions across the world. So we work from headquarters, we work with the countries but through the regional offices. And we have sub-regional offices also. So for example, for the Afro region, there's a sub-regional office in Nairobi and in Dakar. Okay, so as I mentioned, we work under the Department of Country Health Emergency Preparedness, and IHR stands for International Health Regulations. I'll explain that a little bit more. We're basically a core capacity assessment, monitoring and evaluation unit. And we work within the framework of the international health regulations. So that's where One Health is positioned in WHO. But the good news is One Health is in the WHO. So it's small, but it's in there. At the moment, it's mostly comprised of vets, because vets are so happy to get into global health. It's one of the few doors that are open to vets in global health. So it's full of vets. FAO have lots of vets in One Health. WHO have lots of vets in One Health. And OIE have lots of vets in One Health. So sometimes we end up all talking to each other and wondering where are the other sectors. So in time we'll expand that. But the main reason why there are vets in WHO, we can thank the head of our team, Dr. Stéphane Delaroque. He was originally worked for FAO and OIE, and he was brought into the WHO to basically to justify the role of vets in broader than just veterinary medicine, the broader role in zoonoses and even a broader role in food safety, antimicrobial resistance. So while we're a small team of 4 vets, even in the emergency department, in the food sector, there's food safety department, there's vets. We have 2 Rwandan vets at the moment out on mission in DRC working on the current Ebola outbreak. Okay, so what is One Health? I'm sure you've all had this conversation many times, but it's not a thing as such. And you might be a little bit shocked by this, but it's an argument that we tend to have even among ourselves sometimes, that it's not just these 3 sectors, or it's not a standalone discipline, or we're not trying to create a new discipline. It's basically the complex interactions where those disciplines interact, the interfaces. So vets are still vets and medics are still medics, and sectors are still strong within their own sectors. But it's when we come together, or how we can come together and complement each other's work, or to inform each other's work. So talking about complex interfaces, so what do we mean by that? So this is just one example, okay? This is a really messy slide, but that's the reality of One Health. It's quite messy. It doesn't fit into a nice, clean area to work in. So when we come together to work, so this, for example, is a tool we use on joint risk assessment. It's a new tool. It's not finalized yet, but it's in the piloting stage. So this is what happens just when the human, animal, and environment sectors come together and they look at the pathways, the risk pathways. So the animal sector will go aside and they look at all the places in the pathways where a host or a pathogen can jump to the human host, or how it can go through the animals. In the environment, they'll also look at that. So when it comes together, as I said, this is where we work. We're not asking sectors to give up the tools they already have. So if they have a tool for risk assessment or surveillance, we don't say, oh, that's rubbish, you have to do joint. But in terms of certain areas, like certain zoonotic diseases, it makes sense for us to come together. My computer is dying. I better ask WHO to buy me a new one. Okay, so basically it is an approach, and it's very much about collaboration. It's very much about communication and basically getting all the sectors together for a conversation. And that's not easy. It's not easy in terms of logistics, in terms of funding, in terms of just doing it. Because, you know, in the developed world, we're not very good at it. We have a lot of systems that are ingrained, institutions that are ingrained for decades, millennia, and they just, they can't sit down and talk to each other, and then we go out to countries and we tell them they should talk to each other. So it's not easy. Multi-sectoral collaboration is not easy, but we're starting and we're doing it slowly by slowly. So I said that we work within the framework of the international health regulations. So we're monitoring, we assess and monitor, evaluate, and then we plan, and then we look for funding to actually help those gaps that we find during assessment, to build capacity in countries. As Ludwig mentioned, it's very similar to the work, and we actually work together quite a lot. So the international regulations were revised in 2005. Originally they were focused on six diseases, but now it's much more broader, and it has a much more wider scope on health security, global health security. And that has been criticised by some countries because basically all nations, all member states are now mandated to have capacities to deal with the spread of disease and basically have the capacity to respond, to detect, to prepare. Okay, so there's a but in that. So if if WHO states, or the international health regulations developed by the WHO state that now all member countries must have the capacity to respond, detect, prepare. So what are these countries going to say? What are some countries going to say? So can we compare the capacity of countries, say Australia versus the Central African Republic, or is it fair to set the same rules for all countries? So countries argued that it was unfair because they were being asked to be compliant, yet they weren't being given the support to get to the level to actually be able to be compliant. So how can you dictate to countries to implement high-level surveillance, or to implement strong infectious control, when in some countries staff don't even have gloves in a hospital? And that's how, that's where we see the emergence of much disease, such as Ebola, for example. It's not because people don't know how to do infection control. It's not because they haven't been trained in infection control. It's because they just don't have the basic needs that they need just to protect themselves as health workers. So WHO, when these regulations come in, of course, there's always expert consultations. Countries are brought on board, and ideally everyone sits at the table. So basically, the countries argued that if we have to be compliant with this, it should be done at the same time of health system strengthening, because health system strengthening is just as important as being prepared for for outbreaks. And these poor countries still suffer from a lot of endemic diseases that affect them every day that may not affect richer countries. So in order for this to happen, that they really stress that they want to strengthen existing public health systems. And that can be done through key sector collaboration, understanding issues at international, regional and national level. So not just looking at the priorities of the rich countries that don't want emerging diseases on their doorstep, but to look at the endemic diseases that affect people every day in the poor countries or less resourced countries. Sorry. Okay, so what do we do about this in the small department that we're in? What do we do? So one of the main capacity building projects we do is the national bridging workshops. And this is a partnership with OIE. OIE have a tool where they go into countries and they evaluate the performance of veterinary sectors. So they don't go in, they're invited in. So if countries want to know what's the capacity of their own veterinary services or what's the performance, they ask the OIE to come and do this. And a similar tool exists in WHO, and that's called the Joint External Evaluation, or the JEE tool. And that's a tool to help countries be compliant because it forms a baseline. So you know, with research, it's good to always start with a baseline. So countries can know what they have and what they don't have and where they're starting from. And it's quite good to do one of those for the countries because they can use the outcome of that to actually leverage funding from donors, and that donors just aren't coming in every direction doing parallel programs, wasting people's times in workshop when one workshop is going on here doing the same thing as here. So anyone working in developing countries is very familiar with that scenario. So what it's trying to do is identify the gaps. Where are the gaps? And that if it's validated by these tools, then they can justify when writing proposals or when approaching donors, they can justify, well, we've done this tool and we would like to build further capacity within this area. So what happens then with the bridging workshops is it basically brings together the human and animal sector. So the ministries, this is at national level, the ministerial level. So it brings them together and they come with their results and their data from maybe doing the two tools or maybe sometimes not. And they identify the areas where they're strong or areas where they're weak. So for example, the human area is normally stronger in laboratory capacity, whereas the veterinary sector is usually not. So that would be seen as one area where, but they also look at where they work together already. So for example, in rabies, rabies is quite common in a lot of countries still today, but there's very little linkages between the veterinary sector and the human sector. So when a child is bitten by a dog and the child goes to hospital, it may be recorded in the hospital and within the health system, but there might be no connection to the local district health officer, the veterinary health officer, and the dog has gone running away. So it might not be recorded, so it's just kept in one sector. Okay, so that would be seen as a weak. So this bridging workshop brings these people together, and it might be the first time they've been brought together. And when they work together on these type of problems, the walls, the silos between them start to break down, because it's very easy when you're in a sector and you're talking about problems to blame the other sector. But when you're in the room together, it's a bit harder to blame them openly. So this works. So this is a joint external evaluation tool developed by WHO, and it basically looks at 19 technical areas. So it goes to these different areas and it just assesses how is there strengths or weaknesses in certain areas and where the gaps are. Okay. So another key message that came out of the international health regulations and the discussions around it was there needs to be partnership building. So the tripartite is OIE, FAO and WHO, and they have worked together for quite some time. Ludovic mentioned some of the partnerships there because, you know, we share a lot in common: health, human health, animal health, and it's going back even far back as 2008. There was the Tripartite Guide, which was the first publication. So and apart from the human and animal health, there's antimicrobial resistance is now getting a lot of attention. And it's quite a complex area also because it crosses all those sectors. Zoonotic influenza, rabies, every so often different new pandemics or emerging infectious diseases, 65% of them are mostly zoonoses. So the tripartite, as I'm waiting for the next slide to slowly creep up, basically they harness support for the member countries. So by these tools being done and the results and getting baselines, they're in a stronger position to actually access funding to target areas that are important back to the strengthening of the health systems of those countries. So they have more, when they're in partnerships together, it's easier to access the larger donors. It's easier to maybe to guide them. This is, if the WHO says it or the tripartite says it as a partnership, that this is done and this is found and this is where you need to strengthen areas. So that's important for the sustainability. Okay, so another key message is about developing capacities for preparedness response to address zoonotic diseases through the One Health approach. So the One Health was meant, it is very strong in the international health regulations. So basically the tripartite came together last year and they've put together this guide, the tripartite guidance guide, and that's being followed up with a number of operational tools. Because before that, countries were saying, we want to do One Health. We see the benefits of One Health, but there's nothing to guide us. There's no, where do we start from? How do we get together? What tools do we use? How do we work together? So basically the guide was developed out of that justification to fill that gap and that needs for countries. So the health regulations wants the sharing of information. They want supporting joint risk assessments between sectors. And so a number of tools are currently under development. And as I mentioned, the joint risk assessment is the first of those tools, and it has been piloted in Indonesia. And we're under discussion at the moment to pilot it in other countries. Tanzania is one, Georgia, Cambodia, in the next year. So there'll be about 13 pilots done in the next year with some of these tools in countries. So basically, as I said, we're not talking about mixing up the sectors. We're not saying that everyone comes together, but we work between the sectors. And we do that by developing these tools and mechanisms for this collaboration. And here I've just put the human sector and the animal sector because at the moment we're not very strong in the environmental sector. We don't have a big presence. When we have expert consultations, we invite a lot of independent experts from the environmental sector to those. But we're still very much very veterinary dominated. Even within WHO, we still work hard to bring in, to get the buy-in from the medic side. But they're, especially something like surveillance, because they've been doing surveillance for a very long time. And now we're talking about joint surveillance. So the veterinary sector is not as strong in surveillance as the human sector. But we're in the right place to get the right advice in the one house, which is good. Okay, so the One Health, as I said, it's those linkages between the sectors, how they work together. So I just want to give an example of applying this One Health approach of sectors working together, because the guide, the guide does say we work together as sectors, and it includes human and animal health, because the guide is focused on zoonotic diseases. So the human and animal health component is the main components, but we have to consider all other relevant sectors. And I think it's important as well for you that will be doing your research projects, or some of you that are already in research full-time maybe, or want to spend longer time in research, that research is quite interesting, and One Health is quite interesting because you can look at a problem from multiple perspectives. And of course, you all come from multiple disciplines. When I did my Master's in Global Health in Dublin, I was the only vet in the class, and they just didn't know what to do with me. They didn't know who would supervise me, or they just went, this one. I was lucky to get into the course at that time, I think, because it wasn't, vets were not, in global health, vets were not seen as, well, not that they weren't relevant, but they were quite new to the field. So if we look at Ebola, the epidemiologists will have a perspective on Ebola. Epidemiology is the story, what's happened to get to where how did the disease emerge? And they look at the different layers, okay? So they look at the contacts between the pathogen and the host and where that happened, all the way up to the outbreak itself. The vets might have more of a focus on the animal side of things, okay? They're looking for the reservoir host, maybe. We know that in Gabon, those studies done in Gabon, that the duke, or this small antelope, that actually is known to lick the carcass of a dead animal. So that's how it has probably or it's associated with how it's been found with Ebola antibodies. And then other small mammals. So the biodiversity is coming in here. So if say there's a decrease in the larger mammals, the apes and the chimpanzees, does these viruses jump into the smaller mammals, and that these smaller mammals are more likely, there's more of them, and they're more likely to go beyond the boundaries of their normal ecosystem. So that's quite interesting. So Ebola virus has also been found in pigs. Not the pathogenic strains, but the restin Ebola virus. But it doesn't mean that other strains can't jump. Okay, so from pigs, then humans work with pigs very frequently. So that jump from the ecosystem where there has been very few outbreaks. Okay, so the conservationists, there was a big study done in Gabon, and there was really a huge decrease. And we heard today, the world over, the decrease in different mammal species, that there was this big decrease. And of course, the conservationists will look at the influence. So how has this happened? Human activity, increased human activity. Okay. So ecosystem health. So we spoke about this already. Okay. So the reservoir, the transmission cycle. We know that with Ebola, it's closely in the forest. And then as things change, as the balance in the forest changes, whether the larger animals die. Because we always think about Ebola as a human disease sometimes. We know it comes from animals, from animals to humans somehow, either through the natural environment or directly, or else, we don't focus so much on the animals themselves. So I found that these studies were quite interesting because, these mammals that we don't see every day, or that they're not even in areas where tourists would go to look at them, could be dying in large numbers. And then that has a knockdown effect on the rest of the ecosystem. So an area that I'm quite interested in myself, where I focused my PhD, was anthropology, medical anthropology, from looking at Ebola. And anthropology in WHO, the anthropologists are part of the outbreaks and part of the emergencies. But there is also criticism that, anthropology has been sort of the handmaiden to epidemiology. It's kind of, okay, go in there and find out the culture and what funny things those people are doing. But it's not about that, it's much broader. And anthropology hasn't been really seen as the use of anthropology in outbreaks it's not yet appreciated. It needs time because anthropology will look at human behavior in all its forms. It will look at the politics, it will look at the economics, the social, the cultural, the context. The context is so important. As I mentioned earlier, we can dictate to countries, or countries have to be mandated to do things. Oh, people aren't doing infectious control, let's change their behavior, let's focus on behavior change. When people don't even have the money, or they don't have the budget, the ministerial budget doesn't reach their small health units in the villages with the basic requirements such as gloves or disinfectant to do, that doesn't mean that people don't know how to do infectious control. They just don't have the basic resources to do it. And anthropology is quite interesting. And it brings a lot of controversy. We look at the current outbreak in Eastern Congo. And initially they were saying that the people were quite resistant to people coming in on the Ebola and doing surveillance. But you have to stop and ask, well, what's been going on in Eastern Congo for the last 20 years? People have been dying of hunger, of cholera, and war has been going on there. So all of a sudden, a few people are, less than, at the moment, okay, the numbers are increasing, but less than 100 people at some point are dying of a disease, and that's important. So why is that important? And everything else is not important. And these are the difficult questions that anthropologists ask. But they're slowly trying to find their way into the One Health spectrum as well. And it's important, because if we don't address the underlying determinants of health on a global level, then we're just going to be putting band-aids on amputations. Okay. So, as I mentioned, so all of that, anthropology, ecosystem health, social science, vets, medics, epidemiology, virology, it's bring them together, and it's very, very complex. So this is only the human and animal sector coming together to do a joint risk assessment, and this is how complex. When they're doing a joint assessment, they talk about the risk pathways, and this is the mess they come up with. So if you add in everything else, but that in reality is the world we live in. It's messy, So basically, this was just an example given by my supervisor, Liz Mumford, who's also a very strong person in this area. So basically, if the tripartite and other international, regional, local institutions and stakeholders were to collaborate to facilitate the understanding and control of health risks associated with, say, a disease, an emerging disease, MERS or Ebola or something, who exactly would need to be involved? What would be their roles? What would be their responsibilities? So if you were to imagine that you were to do a case study as part of a research study on this, what roles would need to be involved? What would their responsibilities be? What way would it be managed? What would be the governance structure to address those outbreaks? And basically, what kind of leadership? It's not easy. Multi-sectoral collaboration is not easy. It sounds good, and it is good. It is good to get people at the same table. So basically, as you say, we can bring a horse to water, but we can't make him drink. So, as I said, the One Health unit, or the One Health team, it's not even a unit, it's a team, within the WHO is very small. But the most important thing is it's there. It wasn't there before, and now it's there. And we're working in collaboration with within the tripartite. So it's not the WHO on its own. And hopefully soon that the doctors and medics in the WHO will be knocking the doors down to join One Health, that it won't always be the vets fighting their corner. Okay, so thank you very much. And any questions, I'm happy to answer.